My name is Tricia Walkendorf.
And I'm Jim Kendra. We direct the Disaster Research Center here at the University of Delaware. And it is our pleasure to welcome you to today's Fireside Chat with Dr. Anthony Fauci, hosted by Biden Institute Chair Valerie Biden Owens.
The Disaster Research Center was the first center in the world of its kind. Its long legacy of research is the foundation for much of what we know about disasters, how to respond to them, how to recover them, and how to mitigate from them.
This event is in honor of the 60th anniversary of the Disaster Research Center, and it's part of its celebratory workshop bringing together practitioners, scholars, and students from across the world to consider disaster management challenges that are confronting us at this time.
And as we think about the immense challenges of crisis decision-making and leadership, we can think of few better to join us today than Dr. Fauci, whose work is at the forefront of public health, and his work in public health crisis spans decades. We hope that those in attendance will join us immediately after the fireside chat for a reception, to share your thoughts, to interact with each other, and engage in discussion.
And now, please join us in inviting to the stage our Disaster Research Center colleague and Interim Dean of the Biden School of Public Policy and Administration, Joe Traynor.
How are we this afternoon?
I got it.
Whoa. Thanks again to Trish and Jim. Good afternoon. My name is Joe Traynor, and I have the pleasure of serving as the Interim Dean of the Biden School of Public Policy and Administration here at the University of Delaware. I'm happy to welcome the members of the Biden School community and our special guests to tonight's Fireside Chat. This chat in honor of the 60th anniversary of the Disaster Research Center. Named for the 46th President of the United States, the Joseph R. Biden Jr. School of Public Policy and Administration is committed to educating and inspiring the next generation of engaged students and citizens. We're a living lab where traditional education meets hands-on engagement, and students are equipped here every day with the tools to navigate challenging times and develop solutions. We're a place where ordinary people learn to take on extraordinary problems, and they make our world a better place. Because of this, the Biden School faculty, staff, students, and alum are a community of problem solvers and fixers. We're committed to helping communities here in Delaware, in the nation, and around the world. We count among our ranks academics, politicians, government officials, lawyers, policymakers, activists, nonprofit leaders, and even folks in the private sector. We create and apply knowledge. We build bridges. We build bridges across entrenched divides and help people work together. We help them to work together to make this world a better place. We advance innovative and equitable solutions to policy. We consistently step up when other people are stepping away. Who better for our students to learn from tonight than our esteemed guests, both of which know a thing or two about leading in challenging times. The Biden School is also proud to be home and affiliated with many research centers and public service centers here at Delaware, including the Biden Institute, led by our very own chair, Valerie Biden Owens, our host for this evening. Tonight's Fireside Chat is just one example of the amazing programming, the high-quality programming that the Institute organizes for us that benefit the entire UD community and our area. We thank Valerie, Kathy, the entire Biden Institute team for all the work that went into organizing tonight's event. It's also my absolute, wonderful, distinct pleasure to welcome my colleagues from the Disaster Research Center and the broader disaster research community who also worked to bring this event together over the last months and weeks. For over a half a century, the DRC has been at the forefront of innovative basic and applied research that improves crisis management decision-making, and the Biden School deeply values the partnership with DRC and the faculty in DRC all across the university. Everyone should know that that's just a little bit more than a polite acknowledgement from a dean. I've had a front row seat to the Disaster Research Center story for the last 22 plus years. It's been one of my intellectual homes as long as I can remember. Like so many other folks in this audience, the DRC has been a critical part of my story and will always hold a special place. It's an institutional icon of the disaster research field. It's home to cherished founding fathers whose vision and generosity of spirit live on today in the celebration we're having, and in the numerous centers around the country whose leadership came from DRC's ranks. It's a site of deep mentorship and learning. It's a place that's influenced numerous policies and administrative systems, and more importantly, it's a place of discovery and engagement. For those reasons and more, I'm really proud to recognize the DRC's 60th anniversary tonight on behalf of, and offer my sincerest congratulations on behalf of the entire Biden School community. And with that, it's my honor to introduce the 28th president of the University of Delaware, Dr. Dennis Asano.
Good afternoon, everyone. Thank you, Joe, and thank you all for joining us today to celebrate the important work of the University of Delaware Disaster Research Center. And first and foremost, I want to say thank you to all of you who have made it happen. Let's give everybody a hand, including, of course, Jim and Trisha. It's great to see your leadership, and just to be clear, you haven't been at the helm all those 60 years, but we look forward to the next 60 years. The topic of discussion today is decision-making during a crisis. And frankly, I think we'd be hard-pressed to find a better expert to speak on this topic than our guest, Dr. Anthony Fauci. Dr. Fauci, welcome to the University of Delaware. We really look forward to your fireside chat with our very own Valerie Biden Owens. And we are very excited that you're here today to share your insights and lessons learned while dealing with some extremely challenging events in history, including the recent COVID-19 pandemic and the HIV/AIDS crisis. I'd also like to welcome and offer special thanks to our friend and very loyal and valued supporter, Senator Chris Coons. We're always grateful, Senator, that you're with us, and I don't want to say anything else. Without any further ado, here it is, Senator Coons.
Thank you, President Asanas, and congratulations, Dean, to the 60th anniversary of the Disaster Research Center. I suspect, like all of you, I'm eager to get to the chat, so let me be brief. I have the honor of introducing Valerie Biden Owens, a University of Delaware graduate and the successful manager of 7 different campaigns for the Senate and the first American woman to lead a presidential campaign. She spent 20 years with Joe Slade White when she wasn't managing her brother's campaigns, and 35 years on the board of the Ministry of Caring. Please give a rousing round of welcome and applause to the director and chair of the Biden Institute, Valerie Biden Owens. Dr. Fauci graduated from Holy Cross and Cornell Medical School, and he began with NIH in 1968. He's the former director of the National Institute of Allergy and Infectious Diseases at NIH. He was the director from 1984 to 2022. And he's probably one of the most recognized and certainly one of the most widely cited, and in my view, one of the most widely admired public health and scientific leaders on our planet. Most of us know him from his firm, fearless, consistent leadership during the COVID-19 pandemic. I first got to know him during Ebola, when he was a remarkable leader at the Institute, and he's already received the Presidential Medal of Freedom from President Bush for his groundbreaking work in HIV/AIDS. Ladies and gentlemen, a remarkable fireside chat. Please give a round of applause to Dr. Fauci and to Valerie Biden Owens. Thank you.
You know, I think it would serve us both well if we left now. Thank you, Senator Coons and President, and I'm glad you're here. I'm glad he's here. You are an American hero and an international hero, and we are very grateful.
Thank you.
Now, I know that you have been a leader in public health for many years, and that COVID-19 wasn't your first rodeo. Mm-hmm. You have served as an advisor to 7 presidents. Did you have any similar bumps along the road till you hit the tsunami of COVID-19?
Well, you know, Valerie, it's very interesting. People ask different versions of that question, and they usually say, you know, tell me who is your favorite or who is your least favorite.
I know that.
Yeah,
I know that answer.
But in the position as a non-politician, and I'm not a political person, I'm a scientist, a physician, which is my primary identity, and a public health person. But the interaction that I've had with 7 presidents was always determined by what the public health issue during that individual presidency was. And it's really very interesting because the question that often gets asked is that, well, you know, you have presidents with very, very different fundamental ideological backgrounds and ideological implementation of programs. How do you be able to function with each? And there was one fundamental principle that I think will answer the question of all 7. And then we could talk about some specifics if you'd like, is that the first time I got asked to come to the White House to talk to a president, and that was Ronald Reagan. I had been a scientist for my career, and I had not gotten involved in advising presidents. I testified before the Congress multiple times, but not advising presidents. And a very wise person who actually was a conservative Republican who served in the Nixon White House told me something that I would have hoped I would have come to that conclusion anyway. He said, whenever you walk into the White House to advise a president or the president's staff, as you're walking in underneath the overhang of the West Wing, tell yourself, this might be the last time that I'm going to walk into this building. Because if you go in there with the thought that this is really heady, being in the White House, you might slip and tell that person something you think they might want to hear, as opposed to an inconvenient truth that they may not like, and you might wind up getting shot as the messenger. And as a matter of fact, that's exactly what I have done from the very beginning. And I've had to deliver sometimes inconvenient messages and sometimes messages of hope and understanding. And as it turns out, when you do that, you gain the respect in Washington that you are going to tell the truth. And that every president is different, and every president had a different challenge. You know, George Bush had the anthrax attacks. Reagan, George H.W. Bush, and George W. Bush had the early years of HIV. I know President Clinton had the years when HIV was able to go from a death sentence to something that you could give a single pill to. Obama, unfortunately for him, had 3 outbreaks. He had the 2009 swine flu, he had Ebola, and he had Zika. And then when we wound up with President Trump, after his 3 years, we had COVID. And that's when I maintained my same rules of telling somebody something that they may not want to hear. And that's when things turned bad for me, when I did that.
I was going to say, how'd that go for you, you know?
But it's just interesting that when you do that, you get asked back. And history showed that I did that, and that's why I had, in the last 2 years, some of the most gratifying period of time that I had when I served as the chief medical advisor to President Joe Biden. who clearly had the people in mind. And I was talking to Valerie before about, what was the prevailing feeling you get. It was, and still is, a profound feeling of empathy and caring for the American public that transcends everything that he does. And different presidents have different things. We could talk about, George H.W. Bush and George W. Bush. George W. Bush is a good example, Valerie. He's a Republican, he's a conservative Republican, but he felt that with regard to HIV in the developing world, that we have a moral responsibility to see that people don't die of a preventable or treatable disease like HIV merely because of where they happen to have been born in Southern Africa. I really think that's important because it tells you that ideologically you could be conservative or far right and still be somebody who respects humanity and respects, and that's sometimes, in the divisiveness of the country we're experiencing now. I'm very, very worried about that because the divisiveness is really profound. Anyway, that's just a little bit of a long-winded answer to the fact that when you go through 7 presidents, you see an awful lot of swings back and forth, but the one common denominator, with one exception, was a real concern about the general public.
You're a Catholic school kid, so
I am.
we Catholic school kids, there's an expression when you see the light is like, when did you come to Jesus and realize that you had to tell the uncomfortable truth?
Yeah.
When did you decide to get nailed?
It happened. It happened in the first. I don't judge. Again, and I want to really underscore this for the audience. I'm not a political person, and I don't take political sides. But I was getting a little bit nervous in the early years of that administration because of the ease with which you could say something that was egregiously untrue, and that sort of set out a momentum of the normalization of untruths. So I got a little bit nervous, and then about, if ever I got called to have to tell the truth. And since I have a great deal of respect for the office of the presidency, having served so many presidents, I felt that I would have to continue on doing what I had mentioned to Valerie, of just speaking the truth. And my moment of truth, though, as Valerie says, when was the moment, I saw Jesus here of what I had to do, is when it was clear that during the first few months, there was the expectation that the outbreak was going to peak, and just like influenza, it was going to disappear. And the people in the administration wanted it to disappear because they wanted to focus on the coming election. And when they would tell the American public it's going to go away like magic, that's not, but I would say behind the scenes it's going to go away like magic. And then when it didn't go away, then you had to sort of fabricate some deus ex machina that was going to save you. And then along came hydroxychloroquine, the cure-all for that. And that moment when I was standing up on the podium and he said that hydroxychloroquine is going to work, it's going to be the end all for that. And the press said, Dr. Fauci, what do you think? And I was standing behind there. And I said, this is it. I'm going to have to fulfill my responsibility as a physician to preserve my own personal integrity, to tell the American public the truth. And that's when I said, I'm sorry, it's not going to disappear like magic, and hydroxychloroquine does not work. And that unleashed, not necessarily on the part of the president, but on the part of his staff, his loyal staff, a tsunami of an attempt to discredit me, which actually persists to this day. So I did it. If I had to do it over again, I would do it over again, because my job is responsible to the American public.
You are a real-life example of profile and courage.
Thank you.
It takes a lot of guts. In the coming years, do you anticipate any major new crises in I mean, should we leave now?
No.
What's coming on the horizon?
Your question is fundamental to what the issue is, that it is in many respects unpredictable. When you look at emerging infectious diseases, they happen all the time. 75% or more of them, Valerie, come from jumping of a pathogen, usually a virus, from an animal reservoir to a human. Usually it's a one-off, and it doesn't adapt itself to the human species, so it doesn't spread easily from human to human. We see that all the time. I mean, it happens whether it's Nipah or whether it's Hanta fever or what have you, or even Ebola. But every once in a while, you get an emergence of a pathogen that not only jumps species in a one-off, but actually adapts itself to spread from human to human. It usually, or almost invariably, is a respiratory-borne illness, because that's one that can spread across populations and spread easily. And it usually is one that has a high degree of morbidity and mortality. The worst one in recorded history was in 1918 with the pandemic flu, which they referred to as, the Spanish flu. It wasn't the Spanish flu, but it was referred to as that. Then the next pandemic we had was in 1957, and then the next one was in 1968. And then we didn't have one till 2009, and they were all influenzas. But coronavirus gave us a warning, because in 2002, and by the way, coronaviruses are one of the array of viruses that cause the common cold. They generally don't make people very, very sick. In 2002, a coronavirus emerged from the Guangdong province in China, and it was clear it went from a bat to a civet cat, sold in a market, and then spread. Fortunately for us, it did not have the capability of easily spreading from human to human. So public health measures alone were able to contain it. 8,000 cases, 785 deaths. Fast forward to the current time, we now had a coronavirus that evolved very likely from an animal market. But what it had was the capability of very, very easily spreading from human to human. So I don't know when it's going to occur, Valerie, but I know what we need to do. We need to be very, very careful in pandemic preparedness, both from a scientific and a public health standpoint, and put in place the measures to respond rapidly. One, to recognize it, and two, to respond rapidly. With COVID, we did something that was unprecedented. We were able to make a vaccine from the time that the sequence of the virus was recognized in the first week of January 2020. 11 months later, we had a highly effective and safe vaccine going into the arms of individuals. 11 months. That was unprecedented, and that was because of the investment in basic and clinical biomedical research. What we need to do better is we need to have our public health infrastructure be more attuned to surveillance, transparency, and a global surveillance, which, President Biden had tried to do that a few weeks ago. Remember when he came out and said when he gave 50 countries to talk about how we can join together in pandemic preparedness? I hope we wind up that happening.
Yeah, because it seems that some people can see something coming, as the nuns would say, like down the pike, a mile away. They can see it coming right at you. And others don't see it at all. And I'm wondering, are the others just stupid, or the ones who see it coming aren't sharing information?
Yeah.
Do we not just, what's the sharing of information on an international or?
Exactly. You have got to be completely transparent. When you have what looks like a potential outbreak, the natural gut reaction of some countries is to take a look at what impact it's going to have on tourism, what impact it's going to have on the economy. If it turns out to really be a pandemic outbreak, it's going to impact all of that anyway. So you might as well be very transparent about it from the very beginning. And unfortunately, the Chinese were not. And the first few weeks of it was, well, this doesn't transmit very well from human to human. And then a week later, oh, it may transmit a little bit better from human to human. And then 3 weeks later, it's really transparent. It's really transmitting well from human to human. At the time, they were saying that we have it under control. Our satellite images were showing them building 1,000-bed hospitals over a weekend. So that's when I said, whoa, wait a minute. If it isn't spreading so easily, why are you building 1,000-bed hospitals? We should have known that, weeks ahead of time. The South Africans, as a opposite of that, the diametric opposite, when Omicron emerged in South Africa.
What's Omicron?
Omicron is a version of the original virus. Remember, we had the original wild-type virus, then we went from alpha, beta, gamma, delta.
No, I don't know what the hell you're talking about.
No, what it is, when the virus emerges and mutates, it's the same thing. It's SARS-CoV-2.
Okay.
It's a single virus. And what this virus did, and is still doing, that is unprecedented, is that it continues to mutate and it evades some of the protection you get from vaccines and from prior infection. And they give it names when it changes enough to still be the COVID virus, but it gets names that they like to put on it, like this is the alpha version, the beta. In November of 2021, a version emerged from South Africa, and they called that Omicron. They give it Greek names. You're right to roll your eyes when I said that, because these crazy scientists who do this, they give it these weird names. So this one is called Omicron, and a subgroup of Omicron, there are multiple subgroups. What the South Africans did is that they were so transparent that as soon as they saw it, they called me up and they called up the head of the CDC and said, we have a new strain of it. You really better be careful about it. And what happened, unfortunately, is that multiple countries essentially said, well, we're going to stop travel from this particular country. So the thought was, you get punished for being transparent. So what we've got to do, Valerie, is make sure that everybody's on the same boat, that you're not going to get punished for being transparent. You're going to be part of a global community that is very open when things evolve. That's what we need to do.
And you're going to share your vaccines?
Share everything, yeah.
And the profits that come from?
Well, that's another issue, and that's the disparity of access to countermeasures that are life-saving. The developing world had a very, very good point that in the rich countries, like the United States, we were on our third and fourth booster when Ethiopia never got their first vaccine. So there needs to be a sensitivity to global equity, because we do live in a global community. And if ever there was something that proves the global nature of what goes on, is that this pandemic has killed about 20 million people globally. Unfortunately, in the United States, 1.18 million people.
And you think we would have learned a little bit from that?
I would hope so.
With all of the misinformation and disinformation, and what I mean by the disinformation, which has malintent, it's not deliberately not true. And now with AI being so proficient that you can't tell that it's not the real deal, how worrisome is that when this next wave, there are more crises that's going to come to us. Yeah. How are we going to figure this out? And what's happened to good old trust?
Well, the short answer, Valerie, is I don't know. And
but you're supposed to know everything, Doctor.
But one of the issues, and Valerie brings up a good point. misinformation is understandable. Someone gets their facts wrong or they misinterpret something. But what we've experienced in a very destructive and deliberate and malicious way is disinformation, which is the deliberate propagation of incorrect information, which a couple of decades ago would have not had an impact on anything. But with social media now, someone can say something that is completely untrue and really almost egregiously, outlandishly untrue. And it gets into the social media of silos of people hearing what they want to hear. And all of a sudden, something that is absolutely outlandish actually becomes accepted by millions and millions of people. You superimpose upon that the issue of AI, which can, that's going to be disinformation on steroids because it's going to be technologically very, very difficult to go against. What we're faced with is that in our country of freedom of speech, of being able to say whatever you want, if you try to do something at the government level to put a somewhat of a guardrail on the free dissemination of information that obviously is going to be detrimental to the health of the country or to any aspect of our society, you get extremists with help from some of our highest courts say, no, you can't do that. You've got to allow people to be able to say whatever they want to say, and you can't interfere even when somebody says something that is egregiously wrong. And there's a lot of court battles going on right now. There were the attorney generals of Missouri and Louisiana who were, there's a suit against, Biden, Murphy, Fauci, blah, 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 of our saying, and the fact is, all I was doing was counteracting what was an incorrect statement, that you get sued for that. Wow.
Yeah.
Isn't that scary?
I read an article this past Sunday, and it was about a woman with her doctor, and the doctor prescribed a particular treatment for her husband who was dying. And the woman said, that's not true, I'm not gonna do that. It's not true. And that the whole moral of my story is that the issue of trust, where we used to believe, I'm hearkening back to our youth again, in school, if sister said so-and-so, we said, yes, sister, no, sister. Or if your doctor said, you got a broken arm and we have to do it this way, we would say yes. I mean, we'd ask intelligent questions, but now the whole article was about the lack of trust in the medical profession towards what, I guess, kind of what used to be for lawyers, and still is, but now it's, you don't trust your doctor, and how?
Yeah, well, it becomes a complicated issue because when you're dealing with a moving target and science gets criticized as you can't believe science or scientists. Well, it depends on what particular discipline of science. So if you have an evolving outbreak that does change, and that's why I get into, and I apologize for using alpha, beta, gamma, delta, but when you have a virus that's evolving and changes, and the response of it changes over time, you ask the medical profession and the public health profession, you tell us now in January what we should be doing. And when you think you're dealing with a virus that doesn't spread by aerosol, which it does, that doesn't spread from asymptomatic people, which it now does, then if you want to be true to the science, what you've got to do is, as new information comes along, you've got to change your recommendations and change your guidelines, because science in the biological sciences is a mechanism to be able to get information. And by its definition, science is self-correcting. What do I mean by self-correcting? If you look at data now, and the data that's coming in tells you that this is going on, at that time, that's true and that's the right recommendation. If 6 months or a year from now, things change, it's your duty as a scientist to say the data that we now have a year or two later is different and telling us something different. The people who are nefarious and want to discredit scientists say, there they go, they're flip-flopping. You know, they're changing what they're saying. Well, you change what you say when you get new information. And the analogy that I draw on that is it depends what you want out of science. If you're talking about the mathematical sciences, in January of 2020, 2 + 2 = 4. In May of 2024, 2 + 2 still equals 4. If I say in May of 2024, but I changed my mind, 2 + 2 = 6, then you got to worry about me. But if I tell you in January that this is what we know about the virus, and then in May of 2024, I say based on data and evidence, this is now what we should do, that's science self-correcting itself. That gets all bumbled up, Valerie, when people distrust
I want to bring it
scientists.
back to you, though, with your character, because there's something, what you're speaking about is the importance, I think, of a leader who is willing to change.
Right.
And say, now, that was right then, but this isn't, I'm open and I changed my mind. Something that leaders often have a very difficult time doing. The leader that I'm specifically talking about is you. And I think it was something I said. They're not cutting you off, they're just cutting me off. But I want to talk, tell me, I mean, you've been in that, you are that leader who changed his mind. And as a result, it was a profile in courage again of stepping up. But tell me, I'm talking about the HIV. Tell about that, the situation.
Well, HIV was a different story. It really, I think, tells you some lessons. You know, you learn lessons.
Some of us.
No, you should. I mean, you could learn lessons from any painful experience. HIV/AIDS, you know, back in the early 1980s when I began devoting my entire medical career to taking care of desperately ill, mostly young gay men who had this terrible disease. And at the time, the authorities, the scientific authorities, the regulatory authorities, were approaching the clinical trials of drugs and the regulation of drugs in the standard way that we've done in a very productive way for decades, if not longer. Strict entry and exclusion criteria. If a drug doesn't go out until it's gone through 7 years of scrutiny. Well, when the AIDS activists came in, they were trying to get the federal government to appreciate that from the time they were clinically ill, their life expectancy was 10 to 12 months. So you're talking about a process that understandably does well with other diseases, doesn't work for HIV. And I think one of the best things I've ever done in my career is that when the activists, who were fundamentally almost all gay men, were trying to get the attention of the federal government, the scientific community, including me, said, we know better for you. We know what's best for you. We're doing this to protect you. And they said, no, you don't understand. We're all dying. You know, 50% of the people in San Francisco who are gay are infected with this, and 50% of the people in Greenwich Village are infected. The scientific community didn't listen to them. All they wanted was a seat at the table to have input in the design of the clinical trials that was going to impact their life or not, save their life or not. We didn't listen. So what they did is they became provocative, iconoclastic, disruptive, and most of the scientific community ran away from them and said the more they pushed, the more the scientific community pushed back.
What year are we talking about?
We're talking about 1987, 1988, 1986. Then I did something then, and I don't know whether that's due to my Catholic school training or whether it was something. I said to myself, you know, forget the theatrics. Let me listen to what they're saying. And when you listen to what they were saying, they were making perfect sense. And I made the decision that if I were in their shoes, I would do exactly what they were doing. I would be demonstrating, I would be pushing back on the government. So instead of getting them arrested when they were doing their demonstration, I invited them into my office and started a dialogue with them back in the mid to late 80s that led to their input into the process, which made the clinical trial process, the regulatory process, everything better. So that I believe by listening to people who were criticizing you rather than rejecting people who were criticizing you, actually wound up saving people's lives. And that was one of the first lessons that I learned, why I always, even to this day, when someone has an objection, evaluate it on its face value of what it is, because there may be some truth in that, even when people seem to be pushing back against you. That was my world first introduction into what happens when people profoundly disagree with you, is that there may be a kernel of truth to what they were saying.
How long did it take you to bring your colleagues
You know,
in line?
but you know, Valerie, that's important, because then I found myself pitted against the classical scientific and regulatory community, because they would say you're selling out on science, you're siding with these rabble-rousers out there, and I was saying no, they're not rabble-rousers. Just listen to what they have to say. It was an interesting story that I'll be really quick with it, but it just tells you about how things were back in the 80s. I went to San Francisco, and the activist was saying, you know, we have an idea. We don't want to interfere with the integrity of a clinical trial, but we want access to it if we can't get into the trial. So why don't we have a parallel track where you do a clinical trial, you have strict entry and exclusion criteria, but you wind up allowing us to have access with informed consent to a particular experimental drug. I thought that made perfect sense to me. The FDA was completely against it, understandably, because they were trying to protect the American public from a drug that might hurt them. But it was ill-suited to what was going on with HIV. I happen to have developed a very good friendship with George H.W. Bush at the time. And when I got up in front of an audience 5 times the size of this in San Francisco of mostly frightened, sometimes ill, angry gay men, and I gave a town hall, that was my come to Jesus moment then, Valerie, because I got up and one of the activists says, Tony, here's your opportunity. Please come out in favor of the parallel track, which everyone in government was against. So I got up and I did it. And I said, I'm sorry, I'm changing my mind. I think we need to get compassionate usage. Compassionate usage wasn't done then. I didn't realize it, but planted in the audience, I love these guys, it was the New York Times, the LA Times, the Washington Post. So the next day it was front page. AIDS researcher goes against his government colleagues.
Flip-flopper.
Yeah. So when I came back, I took the red eye back and I landed in my office and I thought, well, this is it. You know, the FDA was furious. So I get a call from John Sununu, who was the chief of staff to George H.W. Bush, and said, Tony, what's going on? Because he knew me because I was friends with George H.W. Bush. I said, this is the right thing to do, John. He says, all right, I'll call you back. So he calls me back a few hours later the next day. He says, I spoke to the boss being George H.W. Bush, and he says, he trusts you. Go ahead and do it. The FDA, which at that time was trashing me, comes out and says, we're with Tony all along. You know? It's the truth.
Kathy is giving me the high sign. I have one more question, and it's just, what do you think that we have to do, the leaders, public health leaders, political leaders, what do we have to do to prepare or avert another pandemic?
Well, I think one of the
besides pray.
Yeah, besides pray, we should do that. But besides that, you know, I was struck by, you know, having gone through this with COVID, that one of the factors that I think was to our great detriment was the profound degree of divisiveness which had us do things in a very discombobulated way. It just, I mean, why does a country that's the richest country in the world have 1.18 million deaths, worse than almost every country in the world with maybe one or two? That's completely unacceptable. And what it was there was such divisiveness that we were almost fighting with each other, where you would have leaders saying, don't wear a mask, or don't get vaccinated, or don't do this, or don't do that. It was a fact that is so telling, and history is going to examine this, is that there were more deaths from COVID and more hospitalizations following the availability of vaccines than before. And the distribution of it was, if you were in a red state and were a very conservative Republican, the likelihood was overwhelming that you would not get vaccinated and you would get hospitalized and dying than if you were in a blue state and were a Democrat. Just think about how crazy that is, that whether you live or die depends on what your political ideology is. So, well, what I think we have to do, and I think it's going to be really difficult, is that we've got to get together as a nation and realize that we're more alike than we are different. And this kind of profound tribalism and distrust and hostility from one to the other is the worst possible thing you could have in the middle of an outbreak. It's almost like you're at war and all of a sudden the Navy starts to decide they want to fight with the Army. You know, the enemy is out there. It's not here in the country. And when you're dealing with a pandemic, the enemy is the virus. The enemy isn't the scientist. The enemy isn't the public health person. The enemy is the virus. And I think if we understand that, we'll do fine in the next outbreak.
Okay. Since we are a university and we have students, can you believe it? They have some questions.
All right,
Can you
let's
believe
do
that?
it.
So, it's not Wyatt. You're taking care of this.
Hi, thank you so much for that. I'm Guadalupe Guevara, an undergraduate student at UD. Sometimes certain communities get deprioritized in a disaster or public health response. Agencies might not have time to do everything well, and then it's easy to set aside the needs of those who are already marginalized. What strategy do you suggest agencies use to keep those needs as a priority when times or resources are short?
Yeah, well, you bring up a really good point, and one of the issues besides the divisiveness that I think led to our poor response is the marginalized communities and communities that don't have the kind of access to health care. If you look at in our own country, the hospitalizations and deaths among minority populations, African Americans, Hispanics, Native Americans, Pacific Islanders, is considerably worse than it is among the general population. So one of the things we should be doing right now, of the multiple lessons learned, is that there has to be equity and access, and there's not. And I mean, if ever, you know, sometimes pandemics shine a bright light on some of the foibles and the failings in our society. Epidemics do a great job in showing you that, in fact, we do have a lack of equitable access, and there are still disparities, and it shines a highlight on the issues of the social determinants of health, because the social determinants of health, that if you look at what are the risk factors of going to a hospital or dying from COVID, it's age, can't do anything about age, but obesity, diabetes, hypertension. If you look at the social determinants of health that date way, way back, of diet, economic status, minorities have a much higher incidence of underlying conditions that make them more likely to get very sick and die. That's a fact. So if we want to maybe have one silver lining of a lesson learned from the outbreak, we really have to address both access, but also the decades-long commitment to just essentially neutralize those social determinants of health so they don't exist anymore. But that's not easy. That's going to take decades because it actually took centuries from racism to get there. So it's going to take at least decades to overcome it.
Wyatt?
Hi, I'm Roxy. I'm a PhD candidate in biomedical sciences. And as a scientist, I was studying porcine coronavirus in fall 2019. And it's really hard to explain these scientific matters to a non-expert audience and to have them trust what you're saying. So what are some tips you have for explaining these without taking away from the technical accuracy, but also not over-explaining the matter?
Yeah, I mean, I have some guidelines that I've developed over the years when you're talking to an audience. The first is know your audience, because one of the mistakes that scientists make is that they sometimes talk to an audience that they think is the National Academy of Sciences, and it's a bunch of people who actually just want to find out some fundamental issues. The second rule is to don't try and make 10 points. Make 1 or 2 points, because once you get to 3 or 4 or 5 points, people's eyes start to fly over. So that's the second one. The other one I think is really important is that when you're speaking to audiences, the important thing, absolutely critical, is not to impress them how smart you are, is for them to understand what the hell you're talking about. And often, it's almost an instinct that when you're speaking, scientists tend to think of like they're writing a paper that's going to be in a peer-reviewed journal. That's not the way you communicate with people. You've got to make sure they know a certain fact. This is the fact. This is what we're talking about, and this is the reason for that. The other thing is that when people are not doing what you think they should do, you shouldn't react in a negative way to them and make them feel like they're stupid because they don't understand you. Don't give up on trying to get them to understand and appreciate what you're saying. Sometimes you have to go back more than once to do that. You don't write people off because they don't understand or they didn't quite get it. You just got to keep coming back.
What?
Hi. My name is Giuseppe Lelov. I'm from Italy and a visiting PhD student at the Disaster Research Center. Thank you for being there. Italy was severely impacted by the pandemic early on. Disasters don't recognize national boundaries. Are there particular challenges that need to be addressed so we are ready to confront the next global public health crisis? Thank you.
Yeah. Well, that's a great question, and I think that, and I'll just very briefly repeat it, is what the question that Valerie asked me. We really got to act like a global community. It's really interesting because I've trained a lot of Italian scientists in my laboratory over the years. I've been at the NIH, believe it or not, for 54 years. I came when I was 11, but is that when we were talking about what was going on in China, and we were getting mixed signals, when the pandemic hit the northern regions of Italy, and I called up my Italian friends, they told me that this is something like we've never seen before. And you had trouble believing what was coming out of a sort of a state where the state controls the message. But my first realization that it was going to really be bad in the United States, because Italy is a country that has good scientists, that has good doctors, and they know what they're doing. And if they're telling me over the phone, we are getting overrun, you have to be completely naive to think that when it comes here, we're not going to get overrun. And that was really my first, whoa, we really have a problem. It was speaking to my
What
friends.
month was that? How prior to?
Well, that was in February, February and March when they started getting it. Yeah.
We have one more, right, Kathy? I have time for one more?
Hi, my name is Ronnie Frazier, and I'm a sociology graduate student at the Disaster Research Center. Disasters and public health crises involve people coming together from different backgrounds, disciplines, and perspectives. As a crisis leader, how have you been able to work with these interdisciplinary teams to tackle the biggest public health crises of our time?
Yeah, you got to make the investment of time. You've got to listen to people who are from multiple different avenues who come to you. And it relates a little bit to what the response that I was saying about when I was interacting with the predominantly activist gay community. Because people who are involved from different sectors, they have something to offer. Now, as you know, when you're in a position of leadership, everybody has their own opinion about what to be done. If you listened to everybody's opinion of it and acted on it, it would be almost self-neutralizing because they're opposite opinion. But you got to at least listen to everybody because, like I said, there's almost invariably a bit of a kernel of helpful information from them, even as if you don't completely buy into what they're saying. There's something about what they're saying that is going to help you in your response. That's what I've tried to do, and I've spent a lot of time on Zooms and on traveling with so many, many different people during COVID because it was clear that the outbreak affected people in a different way, and you get a different perspective. So you just got to put the time in.
Thank you. If this was not enough, which it hasn't been, I want to let you all know that on June 18th, Dr. Fauci will have his book published, and it's called On Call, A Doctor's Journey in Public Service. And for Christ's sakes, buy it, will you?
Thank you. Thank you.
Now, one more thing. I'd like to introduce you. You've met our own Dr. Joan Coker. And would you come up, Doctor? And Dr. Coker is preeminent physician in the state of Delaware, very, very active in helping us with COVID, and she was spectacular. And she's also on the board of trustees at the University of Delaware here. And she has something to say and give to Dr. Fauci on behalf of the university. So.
Okay. Welcome, everyone. I knew this wasn't going to be easy because it's been tough on the front line. But when you've got a leader who gets it and speaks truth to power, you can make it. And so on behalf of the Board of Trustees, but more importantly, on behalf of every frontline worker all over the world, Dr. Fauci, I cannot express to you how grateful we are that you stayed where you needed to be when we needed you the most. And thank you for not bowing to expectations, but understanding that science matters and saving our lives. Thank you so much.
Thank you. 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 Thank you.
So we know heroes and we know superheroes. So Dr. Asanas, thank you for the opportunity. So here at the University of Delaware, we do have our highest honor, which is the Medal of Distinction. This is reserved for those who made humanitarian, cultural, intellectual, or scientific contributions to society. They have achieved noteworthy success in their chosen profession, or they've given significant service to the community. Needless to say, Dr. Fauci has far exceeded everything that this medal represents. So on behalf of everyone, thank you for your decades of expertise, your guidance on this global health issue, your countless contributions through the pandemic, and for saving the well-being of folks all over the world. We thank you, and we are so honored to give you this Medal of Distinction. You know I will. There we go.
Thank you.
Thank you to everyone for coming this afternoon. We'd ask, please, that the audience please be seated as our guests exit. And while we're doing that, let's give one more absolute round of applause